I just have to introduce. Good afternoon. Welcome to the Clinician Scientist Interactive Session. It's one of those exclusive sessions organized by AIG Hospital in the best interest of both physicians as well as scientists to interact and exchange the wealth of knowledge they otherwise would not be exchanging without these sessions. And in this sessions, we from the nephrology department would like to present a disease called IgA nephropathy that has been literally causing catastrophic damage to not just the patients, causing a disease across the world, but also increasing the risk of poverty across the world because it affects the young adults and the young kids, causing early need for dialysis and transplants. Thereby, a lot of breadwinners are getting affected by IgA nephropathy. It's so common. Now, I'd request Dr. Murali to explain the clinical pattern that we're seeing in our hospital as what's seen across the world. And then Dr. Purna Chandra will explain to you about some of the genetics we've done to understand the disease relevance to India. And then Dr. Murali will also talk about the future endeavors we're planning to do as part of our Ignite. I welcome Dr. Murali to present.
Okay, good afternoon, everyone. I'm Dr. Murlinath from Department of Nephrology. I'm going to talk about IgA nephropathy and Ignite India Consortium. Now, first, we'll start at some real case scenarios. The case scenario 1 is a 36-year-old male from Hyderabad with no history of kidney disease or other comorbidities. Presented for a routine health checkup and he had no symptoms or complaints, and his blood pressure was normal and physical examination was unremarkable. Next, the case scenario 2 is a 32-year-old female patient from Kolkata, now presents with a 3-day history of blood in urine and mild flank pain, and that is certainly after confirming with her that it's not related to the menstrual cycle, and she had no other symptoms or complaints, and her blood pressure was normal and physical examination was unremarkable. Next, the case scenario 3 is a 22-year-old male from Assam with no history of kidney disease or other comorbidities, now presented with a sore throat and fever for 3 days, and he also noticed a dark colored urine and reduced urine output, and his blood pressure was normal, and physical examination showed this pharyngeal erythema and tonsillar exudates. And to remind you, all these are real-time case scenarios. These are not a virtual case scenarios. So in all the three cases, who do you think has a kidney failure? Let us see. The case scenario 3 on evaluation had creatinine of 1.9. Urine routine showed this 1 plus albumin, and RBC were 8 to 10, and urine protein creat ratio was around 1. And case 2, which was a female with asymptomatic hematuria, had a creatinine of 0.9, and urine routine showed 1 plus albumin, and RBC were plenty, and urine protein creat ratio was around 1.6. And the case 1 was a male patient who came for just a general health checkup. This creatinine was 1.2 and urine routine showed 1 plus albumin, RBC 5 to 6, urine protein creat ratio was 1.1. We even confirmed with the 24-hour urine protein, which was around 980 milligrams. All these had normal kidneys on ultrasound, and all these 3 patients required kidney biopsy and ultimately had an IgA nephropathy. So let us see 2 more case scenarios. A case scenario 4. This is a 40-year-old female patient from Ranchi This presented with 1 month history of swelling in her legs and face, and weight gain and fatigue. And she also reported having a foamy urine and a reduced urine output. The creatinine 1.1 and urine routine showed 3 plus albumin, and RBC were 4 to 6 and urine protein creatinine ratio was 3.9. She also required a renal biopsy which showed IgA nephropathy. Unlike the other patients, this individual arrived at the emergency department. He was a 35-year-old man with a history of recurrent episodes of gross hematuria, flank pain, with worsening dyspnea, edema, and oliguria. His blood pressure was 180 bar 100 on presentation. Oxygen saturation was 92%. And chest X-ray showed pulmonary edema, and the creatinine was 4.2. Urine routine showed 1 plus albumin. RBC was 6 to 8. And after stabilization, the kidney biopsy was done, and it showed a diffuse proliferative GN, that is IgA nephropathy, with cellular crescents in 80% of the glomeruli. So now you can understand how the IgA nephropathy can present with a spectrum of clinical syndromes. This asymptomatic being the most common, that's almost in 30 to 40%. This followed by the isolated gross hematuria. And the classical presentation is a syn pharyngitic, but we only see in 10 to 15% of the patients, where the hematuria can occur with concurrent upper GI or any respiratory infections, unlike the other PSGN, which happens 2 to 4 weeks a gap, and it's called post-pharyngitic. And a nephrotic syndrome, which can occur in 5% of the patients of the IgA nephropathy. And RPGN, that is rapidly progressive glomerulonephritis. This is a clinical syndrome which is characterized by more than 50% decline in the GFR over 3 months or less. And frequently it is associated with an histological finding of crescents in more than 50% of the glomeruli. As we understood that it is IgA nephropathy is most commonly asymptomatic, and IgA nephropathy is usually diagnosed following an investigation for persistent proteinuria and hematuria. So at least a basic workup of renal function test and looking at the serum albumin, and the urine tests which are like a liquid biopsy for us. The urine routine including the albumin and RBC, and urine protein creatinine ratio, and if required a 24-hour urine protein. And currently IgA can only be diagnosed upon renal biopsy, which includes a light microscopy, and immunofluorescence is now a compulsory in IgA nephropathy diagnosis, and EM can be helpful in some handful of cases with podocytopathies. And the Oxford scoring of MES-C scoring, which includes this mesangial hypercellularity and endocapillary proliferation, and segmental glomerulosclerosis, and tubular atrophy and interstitial fibrosis, and crescents. In this image, the A is showing a light microscopy of a normal glomeruli in the silver staining, and the B is showing a mesangial proliferation in the silver staining, and C is showing the C picture is showing a heavy granular IgA pattern in the immunofluorescence. And EM can be helpful in podocytopathies, and it also can detect the mesangial this hypercellularity. So after being diagnosed as a IgA nephropathy, the patients come to us with these questions. These are the questions we commonly encounter at our OPD. What is IgA nephropathy? Why me? And what is causing my disease? What is going to happen to my kidneys? And how are you going to treat me? This last, please consult a nephrologist. IgA nephropathy was first described in 1968 by this French pathologist, the Jean Berger and Nicolas Hinjalis, and who noticed the presence of IgA deposits in the glomeruli of patients with hematuria. IgA nephropathy is one of the most common glomerulonephritis in the world and is the leading cause of kidney failure in individuals under the age of 40 years. You can understand such an young age. And biopsy registers underestimates the true burden of IgA nephropathy. The two caveats of this underestimation is because of the subclinical disease. That is because of the variation in the screening and biopsy practices across the world. And there is also a subtype called the lanthanic IgA deposits, where there is no IgA disease, but we see IgA deposits in the autopsies and donor registries. And the disease course of IgA nephropathy is highly heterogeneous. This is a world map showing different prevalence of IgA nephropathy, of which the China, UK, and these Republic states, and the Japan, Korea, who have a good screening programs, have a high prevalence. But we have to understand that the different biopsy practices across the world. In India, there was one study which showed a prevalence of 16 to 20%, but it is underestimated in the developing countries. Risk equations are, as we mentioned, the almost 30 to 40% patients present as without any symptoms, that is asymptomatic, and 25 to 30% of the patient who has IgA nephropathy reach the end stage kidney disease within 25 years from the time of biopsy. And even after transplant, there can be a recurrence of IgA nephropathy in 30 to 60% of the patients. However, there is only a 5% of the graft loss. So that is a good point for going for a transplant. And the various associations in IgA nephropathy, the commonest are the gastrointestinal diseases, mostly the alcoholic liver disease and any viral infections, NASH, celiac disease, and inflammatory bowel disease, and viral infections and other chronic infections, autoimmune disorders, and the respiratory tract involving the mucosa, the cystic fibrosis, bronchopneumonia, and several neoplasias like IgA myeloma, non-Hodgkin's lymphoma, lung cancer. And before we dwell into the pathogenesis, we need to take a look at the IgA structure. There are two types of IgA subtypes, that is IgA1, which is predominant, and it is the uniqueness of IgA1 over IgA2 is the hinge region, which is long, and when there is this one molecule is called a monomeric. When it combines with 2 to 4 molecules, called a polymeric. So in circulation, we see a monomeric structure, and at the mucosal level, we see a polymeric structure. The hinge region, this hinge region has a serine and threonine residues. This undergoes a sequential glycosylation and a terminal silation with 2 sialic acid residues. And this addition of the galactose is the one which is deficient in the IgA nephropathy patients. So currently the multi-hit model is an accepted idea, and every 5 years there is a new hypothesis coming up in IgA nephropathy. Now in the upstream there is some trigger with infection or an antigen, and the microbes causing this mucosal infection leads to a B cell priming, and with the help of the cytokines like IL-6 and a BAFF and APRIL, these B cells switch on to the IgA cells, and there is a mishoming of this mucosal type of IgA, and this enters into the circulation, that is a systemic circulation. That is the reason in IgA nephropathy, unlike a monomeric form of IgA, we see a polymeric IgA. And the first hit is related to the molecular structure of IgA, where there is a defective glycosylation at the hinge region. And the second hit is autoimmunity, where there is an IgA or IgG autoantibodies, which detects this hinge region as a foreign bodies. And third hit is a formation of the immune complex, and they are polymeric, and and these immune complex are more nephrogenic. And the fourth hit is following the deposition damage to the glomeruli and the tubular interstitial compartment. These circulating immune complexes deposit in the glomerular mesangium, and this triggers mesangial cell activation, complement activation, and recruitment of monocytes, macrophages, or the T cells. And this process leads to the podocyte injury and podocyte apoptosis, and ultimately this can lead to proteinuria. And this fuels up the ongoing inflammation. And local complement activation has a pivotal role in IgA nephropathy pathophysiology, with alternative pathway and lectin pathway being particularly relevant. And with all this in mind, and we should constantly remember that the suggested mechanisms are far from simple and might not account for the diversity that we observe across the different ethnic and the geographic regions. And the questions remained are, is this a one disease or the same disease in different regions of the world? And the exact reasons for the kidney being the primarily affected in such a systemic disease is still largely unclear. So with insights of this, being India being the which bears a substantial burden of IgA nephropathy due to a large population, and there is a scarcity of studies which addresses the IgA nephropathy in Indian context, and the diverse population and the distinctive genetic composition of India present a valuable opportunity to enhance the comprehensive understanding of the IgA nephropathy. And with its renowned expertise, this AIG hospital attracts a substantial number of patients with IgA nephropathy, both primarily and high burden in association with the gastrointestinal diseases. Our kidney biopsy registry here shows almost 35 to 40% of the patients with IgA nephropathy. So with all this, we are planning to execute this Ignite Consortium India, that is IGN Center for Innovation, Therapeutics and Education. The key objectives are to conduct an epidemiological studies to estimate the prevalence and incidence of IgA and identify the risk factors and genetic variants and associated with the disease, and to develop and validate the biomarkers for the diagnosis, prognosis, and the response of the therapy, and to evaluate the efficacy and safety of the novel therapies coming up, and to establish a biobank and registry of IgA patients and their clinical and lab data, and also to provide the education and training to the health professionals and patients on the management and prevention of the IgA nephropathy. The ongoing clinical research currently we are doing one is the study of the clinical profile and outcomes of IgA nephropathy in patients with chronic liver disease, and the impact of clinical pathological features and treatment approach on the outcomes of IgA nephropathy in Indian population, and immunosuppression in IgA nephropathy with chronic liver disease. This is a hot topic because no much studies which shows a secondary or an association IgA research data on immunosuppression. And other ongoing research is a propensity matched analysis assessing the relationship between IgAN and the chronic liver disease, whether it's an association or secondary. We have done one pivotal pilot study which was conducted to uncover the novel microRNAs implicated in the IgA nephropathy in the Indian population. We had included an IgA nephropathy which were only confirmed with the kidney biopsy of age more than 25 years, and we have ruled out our hormonal immunosuppression or kidney transplant treatments, and we excluded patients with any other kidney diseases, active infections, and severe medical conditions and history of cancers in the pregnancy or breastfeeding women. The subsequent about this research about this research will be dealt by Dr. Poona Chandra. Now, currently, other ongoing project is a microRNA signatures in pair patches that we are doing a comparative analysis with the kidney biopsy samples, and will be validation of the dysregulated microRNA along with the key genes involved in the pathogenesis. And the next step in our journey is we are joining a global project with the Columbia University that is with the with the genomic widome sequencing study, where it always involving more than 38,000 individuals, where we identify a new loci and immunological mechanisms. And Ignite consortium at the AIG hospitals will be serving as a representative entity for the Indian cohort. And the principal investigator of the study is Dr. Ali G. Garavi. He's a kidney specialist and expertise in human genetics. Is funded by NIH. So this is a project we are going to be joining hands, where we can, from AIG Hospital, which is being recognized as the expertise of IGA, we'll be involved in this project. Our future recommendations are whether the IGA we are seeing is a secondary or an associated IGA. The differences in outcome between the primary and secondary IGA seems to be very minimal. So suggested that the associated describes better than the secondary. And the gluten sensitivity in IGA, no studies have been conducted on gluten sensitivity in the Indian population in IGA, and therefore we would like to investigate it, and considering the significant number of patients we observe from the North and East India. And early identification and diagnosis of IgA nephropathy, and a better risk stratification with novel biomarkers, and strategies for personalized therapy, and better assessment of treatment response. And we sincerely acknowledge each one of them. Thank you very much. Now request Dr. Poona Chandra to take over for the further research.
Thank you, Dr. Murli, for setting the context for my presentation. In the next 15 minutes, we will dive deeper into the microRNA dysregulation in IgA nephropathy. So before going into the details, I would like to give a brief introduction of microRNA, its biogenesis, along with its clinical application. So as we all know that microRNAs are small non-coding RNA molecules with an average length of 20 to 25 nucleotides. So mostly it presents in almost all the mammalian cells and also present in extracellular fluids such as blood and cerebrospinal fluid. So if you look at the entire human genome, the total microRNA accounts for 1 to 5%, and it regulates at least 30% of protein coding genes. And moreover, these microRNA controls gene expression post-transcriptionally, mainly by binding with messenger RNA or mRNA in the cell cytoplasm. So instead of being translated quickly into a protein, the marked mRNA will be either destroyed and its components recycled, or it will be preserved and translated later. So in any condition, like in any disease condition, if the level of a particular microRNA is underexpressed, the protein that it normally regulates may be overexpressed. So if you look at the biogenesis of microRNA, the initial process like microRNA synthesis is almost resembles like early steps of protein synthesis or a translational process. So in the very beginning, the microRNA gene is get activated, the DNA strands open up, and the gene is copied or transcribed in the form of RNA. So the initial RNA is usually called as primary microRNA. Then the primary microRNA is processed in the nucleus by a group of RNA polymerase III enzymes called DROSHA, where it converts the primary microRNA into precursor microRNA. Later, the precursor microRNA is exported to the cytoplasm through a protein called exportin 5, and where it is further processed by another group of RNA polymerase III enzyme called ISO. So where it gets converted into mature microRNA, which is ideally 20 to 25 nucleotides in length. So once the mature microRNA develops, it goes and binds with a molecule called the RNA interference silencing complex, or usually called as a RISC complex. So then microRNA binds with its target messenger RNA, result in either mRNA degradation or translational repression. So it totally depends on the degree of complementarity between the microRNA as well as the messenger RNA. And moreover, these microRNA plays a vital role in fine-tuning the gene expression by regulating mRNA stability as well as translational efficiency. And it is involved in various developmental processes like influencing cell differentiation and tissue development. Since it is involved in various processes that regulates normal cellular homeostasis, so the dysregulation of these microRNA expression is associated with several diseases like cancers, neurodegenerative disorders, and IgA nephropathy, and many more. So if you look at the typical applications of microRNA, generally microRNA has wide array of applications in clinical sector, maybe a biomarkers for various clinical applications, including diagnosis, prognosis, therapy response, treatment side effects, disease risk and progression, as well as the metastasis in cancer. So some of the examples like MIR1 and microRNA 208 have a potential biomarkers for cardiovascular diseases. So apart from the biomarkers, there are a group of microRNA based therapeutics. So if you look at this panel, there are some microRNAs that are dysregulated in various diseases. They have developed some of the synthetic oligonucleotides that mimics like anti-microRNAs that targets these microRNA which are differentially expressed or aberrantly expressed in different diseases like cancer, polykidney disease, and other neurodegenerative disorders. And this is one of our in-house study where we have identified as microRNA 192 along with combination of CA19 as non-invasive prognostic biomarker for periampullary carcinoma. So in general, IgA nephropathy is the most common inflammatory renal disease and is characterized by the presence of IgA deposition in the kidney. And there are several genome-wide analysis studies revealed that renal microRNA expression has identified a number of novel microRNAs that are related to immunological and pathological changes. For example, the recent study which is published in Nature Genetics, the abnormal expression of microRNA 148b in peripheral blood mononuclear cells might account for the aberrant glycosylation of IgA1, which is a key molecular pathway in IgA nephropathy. Apart from these, there are several other microRNAs that regulates key molecular pathways in IgN, such as transforming growth factor beta, mitogen activated protein kinase, and Wnt signaling pathways. So apart from these serum microRNAs, there are like other urinary microRNAs that could potentially serve as a biomarker for diagnosing and monitoring IgA nephropathy. And however, the potential application of these urinary microRNAs monitoring patients with IgN is still in the early stages of development due to the limited studies and sample size is very less. And the prevalence of IgA nephropathy varies substantially according to geographical variations. So considering this, we have done a pilot study where we have recruited 6 IgN patients. To enhance the statistical power, the same number of control patients were recruited. So altogether, the 12 renal biopsy samples were processed for microRNA isolation, followed by cDNA library conversion, amplification, and finally sample analysis, microRNA sequencing, and followed by sample analysis. And this is a typical workflow of microRNA sequencing that describes the read length distribution of microRNA along with alignment, breakdown, total read count, and the coverage, and also average base quality score per position as well as the per read, and quantification of coverage breakdown in both control as well as the patients with IgA nephropathy. And from the sample analysis, we have identified 67 differentially expressed microRNAs in IgA nephropathy. And if you look at the first PCA plots, that explains the degree of variation between control samples and the test sample. In the heat map, the heat map describes the microRNA signature pattern in control as well as the patient samples. And this volcano plots represents the differentially expressed microRNA, and this is the percentage of microRNAs that are differentially expressed. So from the 67 differential expressed microRNA, 25 microRNAs are significantly dysregulated, and in which 10 microRNAs are upregulated and 15 microRNAs were downregulated. So among this, in general, upregulated microRNA can serve as a potential biomarker for disease diagnosis as well as the prognosis, because the elevated levels may correlate with the disease severity as well as the progression. So if you look at the top 10 microRNAs, The first microRNA 21-5P, it shows highest fold change. So in general, we used to consider this as a potential lead. However, this microRNA is not considered as a considered as a biomarker because it is evolutionarily conserved across all the species, and moreover, it is extensively investigated in various diseases, and moreover, it is expressed in almost all the diseases. So basically, it is a non-specific biomarker. So this is a ruled out case. So apart from this, we have identified 5 microRNAs that shows novel association in IgA nephropathy in Indian population. In these 5, again these 2 microRNAs like LET7G5P and microRNA 30C5P showed highest fold change. So probably these 2 microRNA can be a potential lead for therapeutic leads for IgA nephropathy. However, further studies are required in order to validate these 2 microRNAs. And further, we have constructed a regulatory network of microRNA for the upregulated and downregulated microRNAs along with their target genes. So a total of 990 potential target genes were identified from the top 10 upregulated microRNAs. And microRNA 155-5P showed largest subnetwork that included 375 potential target genes. In case of downregulated microRNAs, almost 1600 genes were identified, in which microRNA 29C and 3P had the largest subnetwork that contains almost 245 potential targeted genes. And further, for this 25 dysregulated microRNA, we have done the gene ontology enrichment analysis in the categories of biological process, cellular component, molecular function, and KEK pathways. So if you look at all these pathways, both in upregulated and downregulated, most of these pathways are associated with the post-translational regulatory mechanisms like MAP kinase signaling cascade and kinase regulatory activity, protein serine kinase activity. Apart from this, some of the microRNAs are associated with cancer pathways like ERBB signaling cascade as well as the Hippo signaling pathway. And as I mentioned earlier that top 10 upregulated microRNA target genes are 900 and downregulated microRNA target genes are 1600. So a total of 2500 targeted genes were identified. So it is a tough job to validate all these 2500 genes. So considering this, we have done 100 genes. We suspected that is there like any transcription factors are associated or not. So from this, we have identified 5 transcription factor for upregulated and 5 transcription factor for the downregulated genes. So notably, among all these 10 transcription factor, SP1 emerged as the predominant regulator among all the genes. So generally, targeting hub genes with the pharmaceutical interventions or therapeutic approaches could be a promising avenue for the future treatment strategies. So from the this pilot study, it has unveiled that a set of 5 novel microRNAs associated with the IgAN in the Indian population. And all these microRNAs have the potential to influence some of the critical signaling pathways involved in IgAN pathogenesis. And further, definitely, further research is necessary to elucidate the particular molecular mechanisms underlying their regulatory roles, as well as to explore their utilization as a diagnostic or therapeutic targets for IgAN management in the Indian community. So basically, this pilot study serves as a springboard for data collection in a larger sample. Thank you.
Thank you very much, Dr. Purnachandra, for providing genetic insights, and Dr. Murli for giving us the clinical insights. Do we have any questions from the hall regarding genetics or the clinical spectrum or regarding our plan on? Yeah, so we don't have to. So if the question is, in asymptomatic patients, do we really have to go for a kidney biopsy or not? So when we say asymptomatic, it is difficult to define, because if you see in Japan, they do screening across the 7th class kids, and then they found that hundreds of kids have microscopic hematuria, which is not symptomatic at all. In those patients who do not have any proteinuria, just simple microscopic hematuria would mean it's not going to progress. So in such cases, we don't need to do a biopsy. But an asymptomatic patient coming with a proteinuria, that's probably an indication for biopsy, because a proteinuria is a harbinger of a progression of the kidney disease. So asymptomatic with proteinuria would be an indication for biopsy. Asymptomatic with just simple microscopic hematuria and no proteinuria would not be an indication for kidney biopsy, unless for academic reasons, but yeah, definitely not an indication. So so that's why we say that IgA nephropathy is underestimated, because we're only doing biopsy for the symptomatic patients. A lot of asymptomatic patients may be missed. In Japan, there are good screening programs. In China, they've started a lot of screening programs, but in India, we don't have. A lot of school kids or young adults who are developing this IgA nephropathy who remain asymptomatic could have been easily missed so far. And that's why we see a need for screening programs, if not in school kids, at least in corporate companies where they have an insurance coverage, majority of them, the tech companies, and a urine examination, simple urine examination, help us pick up these cases. A lot of patients we see are young adults. Sometimes it's catastrophic to see how their families have to bootstrap all the resources and then fund the kidney transplant for this. Definitely not a good sign for India to see these young adults.
So my suggestion, microRNAs have to be now screened in the plasma. So that becomes,
Right, yeah.
192 is upregulated in the plasma
Right,
of
yeah.
periampullary cancer patients.
Right, yes. So
this is validated.
right, yeah.
In the plasma, then it becomes a marker.
Right, that'll be useful. I think that's a good idea. But we also did not find 148 that was found in some of the East Asian studies. So we were also surprised why we did not see some of the microRNA markers that are seen in East Asian countries. We have been thinking that we see a high burden of IgA nephropathy in this hospital because of the presentation from, because we get a lot of cases from the northeastern part of the country who have potentially Oriental race, but it's surprising to see that even these patients don't seem to match well with the lineage of Chinese or Japanese. We're still not very sure what we're dealing with. And when we had a discussion with Dr. Ali Garavi, it was a lot more clear to us that maybe microRNA, as we stepped a little early into it, because it seems to be a lot of gray area. It seems to be ocean. We're nowhere closer to identifying correct target. So maybe a genome-wide association studies may be a good beginning for us. That's why would probably be using NIH grant for that particular study. Please try. Known triggerer. Right. So they say the aberrant glycosylation that's triggered from Peyer's patches, the IgA from Peyer. So IgA is present predominantly in gut and sinuses. So the hypothesis is that when you get sinusitis or recurrent upper respiratory infections or GI infections, then there's some kind of abnormal aberrant glycosylation gets triggered. We're not sure what the trigger is, but this is one hypothesis. Yeah, please.
Then probably there would not be need for any renal biopsy, and IgA can directly come into the circulation, and that could be one of the way to easily detect it. That we can.
So, sorry, what's the question? You're
Sir,
saying that you would want to lyse the multimers with the, and then make it monomers.
Yeah, in the
use
monomer
those
form.
monomers
Yeah.
as the plasma biomarker,
Yeah,
and so you can avoid the kidney biopsy.
yeah.
So the marker might tell us that there is an IgA burden in the body, but we won't know whether that IgA has attacked kidney or not. So the mere presence of abnormally galactosylated IgA does not mean that there is a kidney disease. This abnormal galactosylized IgA has to bind with complexes, complement complexes in the kidney, and then cause disease. So what causes the kidney disease? Why only in some patients the IgA binds to complements, mediated complexes, and then causes kidney disease, and not others, we don't know. And then the second, so merely picking up IgA may not really help us whether the complement mediated damage is occurred or not in kidney. The second thing is that the IgA has very heterogeneous presentation. So even if IgA has deposited in glomeruli, it does not mean that it led to a kidney disease. And plus, in some patients, you would see some degree of fibrosis, some degree of interstitial damage, all that you would only know in a kidney biopsy. So that's why the kidney biopsy is quintessential in diagnosing IgA nephropathy, which you won't get by biomarkers, serum biomarkers. But serum biomarkers will be helpful if you have no hematuria and no proteinuria, and you probably tell somebody that, okay, you're at risk of IgA nephropathy, just be watchful. Get your urine examination every 6 months. That's when your idea is very valid, where we could use that as a parameter to tell that something might happen to you. Keep a close follow-up of your urine examination. That's where we go.
And it appears like galactosyl transferase enzyme is defective in this case. So, like, will the supplementation of this particular enzyme help in like reducing the severity of the disease?
That's a great question. You have any answer, Dr. Murli? I have no answer. Maybe Dr. Murli can help us.
Hit 1 and hit 2 and hit 3. Only the hit 1 is not essential for developing an IgA nephropathy. Even there must be an antibody, and there must be an antigen antibody immune complex, and these immune complex must be damaging the kidney. Then only we'll be exhibiting an IgA nephropathy. Only if you're trying to inhibit the glycosylation, or only as you asked, the IgA, if you're able to identify as a biomarker, already those studies have been done. It has showed a sensitivity of 80% and a specificity of 78%, but it's ultimately not useful in diagnosing an IgA nephropathy. You must have an hit 2 and hit 3 and hit 4 ultimately causing an IgA nephropathy.
Well, what she's saying is, I think what your point is pretty valid, that you need to have multiple hits to really manifest. But her question is, okay, I can't handle all the 3 hits. Maybe if I just address one hit, that is preventing abnormal galactosylation, just one part of disease burden can be prevented. Because at least when you prevent those abnormally galactosylated molecules, you prevent the antibody response to those. So will I be able to use the enzyme methods to prevent that particular pathway?
There's one also hypothesis, as you mentioned, like because glycosylation, but there is another route through this bone marrow where it also enters the circulation. that this abnormal glycosylation will not explain that.
Maybe we could.
Only a part of the glycosylation is secreted to the mucosa and is mishoming and entering into the circulation. But there is also an entrance from the bone marrow.
Yeah, there are multiple mechanisms, but to address your question, maybe again we'll review the literature and see why that cannot be addressed. Thank you. Any other questions? If there are no more questions, we really want to thank all of you for attending this session, and then we look forward to attending more of this clinician scientist sessions that have fostered the knowledge exchange as well as better understanding of basic science techniques to physicians as well as clinical sciences to scientists. Thank you once again for coming to this afternoon session. Take care.